Welcome, everyone. Well, I have a great guest today. I'm really looking forward to this conversation. Her name is Kathy Steele. She's a psychotherapist, consultant, trainer, and author. She practices in Atlanta, but she works with complex psychological trauma, and we're going to be looking at today's dissociation and trauma. She's written 2 books on it, Coping with Trauma-Related Dissociation, Skills Training for Patients and Therapists. And her most recent book is Treating Trauma-Related Dissociation, a Practical Integrative Approach. And this is really fascinating, folks. And I know if you've been following me, you know that we've covered a couple of different episodes already on trauma with different individuals. We had Dr. Porges here a few weeks ago talking about polyvagal theory. We had another, lost my mind, Danielle Asif. She came on as well talking about trauma. So we're looking at trauma today at the dissociation lens, which is really fascinating to me. So let's find out. Stop wasting my time, right? Let's go. So welcome, Ms. Steele. How are you?
Hi, Carlos. How are you?
Doing great. Thank you so much for being here.
Well, thanks for having me.
This is an interesting concept, and I guess what dawned on me for the first time when it really hit me was when I read Dr. Alan Shore's book. And he was talking about neurobiology and dissociation and all that.
Right.
And when I started looking it up, I found your book, which I found really, really insightful. So why don't you tell us a little bit about this dissociation and trauma?
Yeah, it's a pretty big topic, but I think I would make a little bit of a distinction between the common everyday use of dissociation, which is like checking out, shutting down, not being aware too much, which sometimes we call it zoning out or spacing out. Everybody does this. It's totally normal under stress or when we're tired. And of course, when you've been traumatized, you do it more. But the kind of dissociation that I'm used to working with a little bit more is more involved. It involves sort of a division or a fragmentation, or we might call it a compartmentalization of self, so that people have sort of different senses of self that they shift in and out of as a way to avoid and cope with the trauma.
I'm not sure if you're familiar with Donald Koscheld's work.
I don't think so.
The Jungian therapist who, I think he wrote a book called Trauma and the Soul. Either way,
Yeah.
he talked about something, because when you said compartmentalize the self, he kind of makes it out to be like, he uses the term dis from Dante's Divine Comedy, where he has this individual that houses this self to protect them from whatever trauma is happening, because the person can't process it. Since it's an acute trauma, they can't process it. So this kind of protector, Mephistopheles, whatever you want to call him, protects this part of the self away. You like that depiction, or do you have a different type?
I think that's one good way to think about certain types of compartmentalized selves. Yeah, that you get a part that just is sort of stuck in the trauma, and another part of self that is trying to just go on with daily life and avoid the trauma like crazy so that you can go on with daily life. And that just keeps maintaining this internal split.
And does that internal split cause us to perceive the world in a different way?
Well, it can, because you can perceive the world from the perspective or from the lens of the part that's stuck in trauma, who thinks the trauma is still happening in some ways. Or you can perceive the world and other people from a more grounded perspective in the present day reality. And so this is why people can switch back and forth between flashbacks where it seems like things are happening in the past when they're actually perfectly safe in the present. And that's sort of the definition of post-traumatic stress disorder.
Yeah, absolutely. Fascinating. It kind of reminds me a little bit of the allegory of the cave in Plato, doesn't it?
Right.
They only see the shadows, but they don't want to go out into the real world.
Yeah, because it doesn't feel safe in the real world.
Does that also lead to resistance with therapists? Is that when a therapist engages into that sacred space, I guess you could say, wherever they're keeping themselves, and the therapist bumps up to it?
Right.
We see, is that when resistance pops up? Or at least one example?
Yeah, and I like to think of resistance more as protection, because resistance kind of has a bad name, like a client is doing something on purpose to defeat the therapist, and it's really not about the therapist at all. It is about protecting something that feels so vulnerable. And so I think the therapist task there is to try not to bump up things too quickly, too hard, but just to really explore how can we help this client develop more capacities and more confidence in dealing with these issues first.
I like that. And are there degrees of trauma?
I think there are degrees of response to trauma, and that doesn't necessarily correlate totally to the severity of the trauma, right? Because some people might be much more affected by one event than another person. But we do know that certain kinds of traumas, and maybe Stephen Porges talked about this a little bit, kinds of traumas where you are immobilized with fear, that they can be more devastating to us. Any kind of trauma that's interpersonal and that involves people, that are in authority over us, and the younger the age that we experience trauma, the harder it's going to be to deal with it.
I can definitely see that. I'm definitely going to that direction in a couple of minutes. I really want to explore that a little bit too with you. Well, actually, I'm going to have to, because I think I forgot my question I was going to ask. I had a question and it just drifted away.
That's all right. It'll come back.
So childhood trauma, that's pretty powerful. When I'm looking at different journals and reading studies and books, the children under 3 or 4 or 5, right, when their cognitive abilities are really not fully developed, they have a limited amount of vocabulary and understanding of the world. That seems like trauma, they process it differently than an adult. Is that accurate to say?
Yeah, I don't know if they process it differently, but they encode it differently for sure. They encode it in a much more sensory motor way, so that they may not have clear memory like we would think about, I remembered what I did yesterday. They wouldn't have any visual necessarily image of it, or very fragmented. They wouldn't have a cognitive frame around what happened. And so those kinds of what we call pre-verbal experiences are particularly challenging to deal with, because they don't seem to have a context. And that can be quite scary and overwhelming.
Absolutely. And the interesting, because when I've talked to you before a little bit before the show about, I do a lot of work with law enforcement and whatnot, and I have seen some distinctions, and I'm not sure, I'm just trying to get your opinion, I guess, on this. I've seen some distinctions between child abuse, whether it's physical, sexual abuse, between the biological parents or from biological parents compared to strangers.
Right.
And because, the parents are there supposed to be there to protect us for security, availability. And when that parent turns into be the monster itself, it turns our world upside down. What's your take on those two?
Yeah, I agree that there is a significant difference, because with our biological parents, we are actually evolutionary prepared to attach to them. But we're also prepared by evolution to defend against danger. And so when you try to put those two things together, I need to be attached to the same person I need to defend myself against. That sets up a sort of insoluble problem for the child that they really can't fix. And so they often alternate back and forth between defense and attachment in ways that aren't very adaptive, or it's like they sort of blow a circuit and become quite disorganized and disoriented, and it develops a particular kind of attachment style called disorganized, disoriented attachment. And what we know about that is that dissociation is highly correlated with that kind of attachment style.
Interesting. How does that work in regards to disassociation? Why do people disassociate?
Well, I think we dissociate when we can't tolerate what's going on for whatever reason. Maybe we're too tired, we're sick. But in the case of trauma, it's because we don't feel like we have the resources and capacities in the moment to deal with it. And so it's the body and mind, and of course the body and mind can't be separated. It's our way of protecting ourselves against what we believe is intolerable.
It almost sounds like it has an evolutionary principle behind it.
I think it does.
Yeah.
And of course, Stephen Porges talks about dissociation in terms of this shutdown, this dorsal vagal shutdown. But I think the dissociation of the self that I see often, it has a little bit different dynamic that we could really locate in the disorganized attachment, where some part of the self is moving toward trying to find ways to connect with other people. And another part of the self is trying to find a way to defend against connection and defend against threat.
Fascinating discussion. I know we're switching gears a little bit now. I remembered that question.
Oh, good.
It came back up. I had to write it down this time. As we're heading towards treatment and some of the work you're doing, and of course relating to your book again, folks. Her name is Kathy Steele, Steele. Resilience. I always get this question a lot. Well, how does somebody become more resilient? And how is somebody who's in Syria, for instance, you have an incredible devastation of an entire town. Not only did you lose maybe family members, you also lost your entire history in some of these places, because the entire town is obliterated, so there's nothing to go back to. There's no nostalgia at all. How do some people cope with it? More resilient to it compared to others?
Well, we know that there are factors in resilience, and one of the factors is social support. If you can find social support somewhere, someone who can support you through it, then the odds are you're going to have a little bit more resilience. Another resilience factor is just your temperament and genetic background, right? What you're given at birth. Some people are more resilient than others because of temperament. I think the ability to make meaning out of our experience is important. I know Viktor Frankl, who was a famous analyst who was in the concentration camps in Germany, talked about Man's Search for Meaning. That was one of his central books about what's important is that you make meaning, a positive meaning out of what you've gone through. And so I think linked to that is not something people talk about too much, but the capacity to have positive emotion and positive experiences and not to dismiss them or minimize them. That is a huge piece of learning to be resilient.
Great insight. I like Viktor Frankl a lot.
Yeah, me too.
As we get into the types of treatment, I'll ask this question, but I guess you can determine when you want to answer it.
Sure.
A lot of people say, for instance, individuals, again, if we look at that self, let's put it in a little compartment, to be able to self-actualize fully, you're going to have to go and face that self that's been locked away and the evils that are there, the shadow and the Jungian world, whatever it may be. Do you find that to be accurate?
Yeah, I mean, I think that's true for all of us, that integration, to be a fully mature, adaptive person, we have to sort of know ourselves fairly well. I mean, we never know ourselves completely, but we we have to really know what our strengths and vulnerabilities are, and positive and negative qualities. And we have to know what our experience has been, our history. So yeah, I think it's accurate. And I think it's a very, very hard thing to do in trauma.
Yeah, very hard to do. Let me ask you this. I'm trying to make this as specific as possible. Psychologists never like this question. I don't blame them. Because it's too broad, right? But how would you work with somebody who's disassociating with trauma? Yeah. Maybe you can pick one case.
Well, it is broad, but okay. I do have a kind of succinct answer to that. And the first thing I would do is really assess the resources and capacities of that individual and see where we need to build that up. And so I would begin not with focusing on traumatic memory, but with focusing on stabilization and capacity building, right? And then we could look at how avoidant or how much this particular individual is able to approach these sort of compartmentalized selves and slowly go at that in a way that's at their pace. And only then would we probably begin to touch on traumatic memory as they feel like they can stay present and grounded, connected to me, and connected to themselves.
I know a lot of would-be therapists are listening to this right now. A lot of fledgling therapists out there who are going to be listening, wondering, how do you approach that? And one of the things I usually tell them is it takes time to learn, right? How much you can push your client, how much you can't. I share a story once when I was interning years ago. I can't remember what I said to the woman at the time, but she brought up an incident that happened to her. She brought up that she was raped by her 13-year-old brother when she was 10 for a year. And then she went into a catatonic state.
Oh boy. Yeah.
Yep, didn't move, didn't do anything. And I'm looking at there going, what just happened to me? Because this was literally about 2 months into my internship, and I was really throwing it back. So give us some insight on that.
Well, I think pacing is really important. And I think trauma clients are almost always conflicted. I want to know and I want to tell, but I don't want to know and I don't want to tell. And so I always assume that's there. And if it's not there, it's great, but I will assume that conflict is there first. And we'll explore that first and look at capacities. And if somebody is just about to tell me a whole lot of trauma early in therapy, I will stop them and just say, what do you notice is happening inside of you right now? Is there any part of you that doesn't want to talk about this right now? You know, and I'll get a feel for how activated they are, both in terms of maybe hyperarousal, or in the case you described, hypoarousal, right? Because clients can sort of blurt out the trauma in a way that overwhelms them in the hope that if they get it out, it will help. But then, of course, getting it out is not the right metaphor. It's like they have to digest it, and they have to digest it slowly.
Like that, yeah, it's absolutely true. It's great. It does take time to be able to figure that out. So in your book here, you talked about treating trauma-related dissociation, and you call it a practical integrative approach. I guess one of the things that popped up in my mind is I've always found an affinity towards Gestalt, and especially when he tries to connect the mind-body. Is that something you would do as well?
Yeah, I've had a little bit of training in Gestalt decades and decades ago, but I think this idea of really beginning to help a client access both their sensory experience, their emotional experience, their cognitive experience, their relational experience all at once. Of course, that can be overwhelming, but to bring those elements together in a way that the client can tolerate is actually a big part of therapy. And so, for instance, in Gestalt therapy, you would have this empty chair technique where you have a dialogue with a part of yourself. That might be a little more scary in clients who are dissociative, but some form of inner dialogue is part of what we want to do to help the client feel more connected and integrated at their own pace, of course.
What do you think about creating more distance with like metaphor therapy or dream analysis with the Jungian style, where they're kind of distancing from that actual event?
Yeah, it's possible. It depends on whether the client is able to use metaphor or if they're a little more concrete. Sometimes if I use metaphor with a client who's not ready, they start seeing the metaphor as kind of overly real and they get really emotional about it. So sometimes I can talk about a little bit taking small steps, like, could you imagine talking about it? What do you think you would be feeling if you were talking about it? That's kind of a step behind. Or what are you worried about if you talk about it?
Okay, I like that too. Great stuff, folks. Again, it's Kathy Steele. The book is Treating Trauma-Related Dissociation. That's just one of her books. She's got the other one, Coping with Trauma-Related Dissociation. Fabulous books, really good stuff. In our last couple of minutes, Kathy, what do you think is one of the most important things for people to understand about trauma if they've experienced it right now? What would you advise them to do? Of course, see a therapist, mental health professional, but what else would you advise them to do?
I think one of the challenging things about the kind of trauma we're talking about is that it sort of strips you of your self-esteem and self-worth. So anything that you can do when you've been traumatized to have compassion for yourself, even if it's just having compassionate intention toward yourself, if you can't feel the compassion, and to engage in good self-care, physical, emotional, spiritual, relational self-care. I mean, I know that's a lot to ask, but any little tiny pieces of that you can add to your life can be really helpful.
And they can do it incrementally, right? They can just one.
Yeah. Well, we all do it incrementally, right? Excellent. Sure.
Wonderful stuff. Thank you so much for being here.
Thanks, Carlos, for having me.
Fascinating discussion, Trauma and Dissociation with Kathy Steele. Again, the books, Coping with Trauma-Related Dissociation and Treating Trauma-Related Dissociation. Fascinating reads. If you're in the mental health profession, I highly recommend it. Folks, if you want to support our podcast, make sure to share and subscribe. Thanks for listening, everyone.